Good morning. Welcome to our monthly webcast. I am Samir Mehta, your moderator. To begin with, a very happy new year to you all. We start session 79 today with the genuinely complex calcified and long CTO, which hopefully you'll find very instructional to help you with your decision making, antegrade, retrograde, what kind of equipment, and with this brief introduction, let me take you to the cardiovascular laboratory where Dr. Kinney and Dr. Sharma are standing by. Good morning, Samin.
Good to see everybody.
Good. Selected the new year with a truly, genuinely complex case.
Yes, I mean clearly of the various cases which we have seen over the years, where we are highest the hits in terms of learning objective point of view, the bifurcation, left main, and then the CTO. CTO really right up there. So we felt that few cases this year we'll start with the CTO cases with the technical challenges and try to upgrade everyone in terms of those steps.
15 groups of interventional cardiologists around the world already keyed in.
Good, beautiful. So now I'm sorry for a little delay because we had some audio visual issue. With that note, I think we start the case knowing that this case may take little extra time than usual, because being a CTO, very times it's predictable, but sometimes it's unpredictable, particularly if we have to go to the retrograde approach in this particular case. So if with that note, I think quickly we can go with the case presentation with our supporters, which we always thankful. These are the disclosures which have not changed. And then this is the, as you mentioned, case number 79. It's a 78-year-old patient who had a longest standing history of a stable angina. He actually has been advised to have cardiac cath in the past but refused, although had positive stress test. Now he has crescendo angina class 3 and has a stress MPI positive both for anterior as well as inferior ischemia, and has a mild LV dysfunction. Cath also revealed 2 vessel disease with the mild LV dysfunction, vessel being 80% proximal circ and 100% proximal LAD. So at that time patient had a PCI of the circumflex, age being 78, and was okay on medical therapy FFR for so long. So we decided this was FFR guided PCI of the circ, done well, and decided on just medical therapy. There was no plan for stage intervention, and he had been on good anti-ischemic medical therapy, or knowing that we could not go much on beta blocker because of his asthma and COPD. So this basically his original angiogram with the syntax score of 26.5 cath findings, and the LAD is very big, and we'll show you very quickly, and the basically had a stent of the proximal circumflex. Now Anu, can you show it?
Yeah.
So this is the LV, anterior wall hypo.
But still there is ischemia there, yeah. And this is where we have a dual injection. RCA is okay, the circ stent looks fine, and LAD, which is total, just I would say after the, is proximal total. Little subtle you may see, but I think the challenge here is you have disease right from the ostial LAD, and then you don't see the proximal CTO where it starts calcium, but the length of the CTO is very long, almost like a 30 millimeter long CTO, and then after that the vessel is still diffusely diseased almost up to mid to distal part of the LAD. If we same thing, I think the approach wise we will still consider a antegrade approach, and this view is a very good view where you can see that there is both septal collide. There's one good septal that is right at the center that goes all the way up to where I think the distal cap of the CTO is, and as well as a good epicardial collateral, and we always have gone through this point that we have never tried any epicardial collaterals as a channel if you are doing retrograde.
Yeah, so it's a good collateral. So, but both, if we need to go back to the retrograde, we'll go through the septal retrograde collaterals.
Yes.
It's a large vessel, but clearly show the other view, which is a little more unfavorable because of proximal LAD lesion. There is ostial LAD also.
Yeah, if you see here.
And there is a moderate calcium.
Moderate, two things against us. I think I would say moderate calcium, but more important is the length of the CTO.
Right.
But the disease starts right at the ostium of the LAD.
And a very blunt CTO.
Yeah.
And the blunt CTO. These are all important points.
Yeah, and
length,
the side branch.
Length, the blunt CTO and the calcification. So coming back to our slide presentation.
So, before you start the presentation, I mean the traditional thinking would be that initially when you saw this patient, why not go for the more difficult CTO first?
That is true. In this particular case, because of the patient's age of 78, we felt, knowing that this probably LED is for long time, and the referring physician also just wanted to take care of the culprit vessel, and clearly the culprit was the circumflex.
Excellent.
So that was the reason. Now, clearly that, you know, of course, once you have one vessel disease, this patient who has refused cath procedure for last 7-8 years continues to be symptomatic, and for which now he has been brought back for the LED CTO, which was not a plan back in October. So therefore, what I wrote down here, if you go back to my slide, planned PCI of the LED CTO via integrate or retrograde collateral at present. So we are not talking about, this was not a plan or staged. Idea was do the culprit and we are done with it, and of course it's still appropriate with the proximal LED and patient ischemia and anti-dual ischemic therapy. So now AK, you are ready to start. What will be the goal now?
Yeah.
So while we presentation, so basically will be the same fine cross, and we'll start shortly. Though I have a limited presentation, a short one today involving the case, because of we probably, as I said, will devote more time into the issues, I mean the actual case. So there are two important issues which have come up. One is the MACE and the femoral vascular complications in relation to radial procedures, volume in contemporary practice. This is a very tricky topic which you can see here. You say, what are you talking about? And I'll show you what I'm talking about. Second is the changing predictors of the CTO recanalization success in contemporary era. The most important is the MACE. We know the latest trial of the matrix showing radial versus femoral. Overall, radial is superior, lower primary endpoint, lower mortality as shown here, lower bleeding, every way plus. So you say, well, then where is the controversy? The radial does so good compared to the femoral axis, and of course whether you do a bleeding or not bleeding. And basically what it turns out to be that if you see, there is a gradient of the outcome in the matrix trial in various radial centers, and they counted radial center as the 20 to 65, 65 to 75 and 75 to 90. So clearly the low, intermediate and high risk, and if you can see that really the benefit was in the high risk cases, high risk or high volume radial centers. So you say, why, what does that mean? And this actually led to the numerous letters to the editor in a Lancet on this article, and this is basically is the boils down to radial is in red and the femoral is in blue, basically the low radial PCI center, intermediate radial PCI center and high radial PCI center. Look at what is going on in these three centers, and one in terms of the death MI stroke, which is the primary endpoint, second is the bleeding, and third is the mortality. And this is actually the first time has come to this issue. And then see the mortality. Clearly, the primary endpoint 1% higher in the intermediate radial center, and actually they are quite higher into the high radial center. Even we are talking about the patients with the in the death MI in the radial groups. So radial group was gradient of 8, 9 and 10, and for the femoral in these center was 7, 8 and 15. So tremendous. Second, the bleeding. So bleeding was 1% high. Huh?
P-value.
Yeah, no, will come. And clearly the bleeding in the high radial centers, bleeding is higher, particularly the femoral bleeding. And lastly, the mortality, 1% higher mortality in the patients with the high radial center. So question is, and the p-value basically for radial, there was a high versus low 0.02, but significant p-value of 0.0001 for femoral PCI in high versus low radial center. What does that mean? That basically means that patients in high radial center, where it is done in 80+% of cases, they are associated with higher MACE rate, one in the femoral group. So the difference overall, which looks like the patient level, that it looks good, that you have lower MACE rate, but for the population level, you actually have those centers have a higher complication MACE as well as bleeding as well as mortality, 1 point difference. Now you say, well, this is the first time we are hearing it. Well, key is in the matrix trial, they selected the center which were very proficient in radial. So this was not seen actually in the rival trial, some trend was there, but majority in the matrix trial, they preferred the radial centers for this acute coronary syndrome, and this is the differential MACE. Now, is this the first one? No. There is another report from the Euro intervention that patient undergoing PCI from femoral root by default radial operators are at high risk of vascular access site complication. And you look at the complication, 12.5%. Vascular femoral complication, unheard of it. So clearly happens in these. So therefore, what they said, the editorial, the use of radial access decreases the risk of vascular access site related complication at a patient level, but is associated with an increased risk at a population level. The radial paradox by Dr. Azzolini from Canada. And this actually has put into the right perspective by the study which they came up few weeks in a JACC intervention, that the benefit conferred by radial access for cardiac cath are offset by a paradoxical increase in the rate of vascular access site complication with femoral access, and they call it the Kempau radial paradox. You say, what is Kempau? Kempau, Lucien Kempau is the first guy who reported the radial interventions in our literature. So he was basically from Canada. They call it a Kempau paradox, and paradox basically was, what they did is they compare the historical control where it used to be femoral, and then in the contemporary cohort compare femoral versus radial, and idea is to see that truly in the radial group, now once we convert it to radial, are we having higher femoral vascular complication or vascular complication per se. So this basically was the whole issue, and it turns out to be absolutely yes. As you can see, in the earlier time period, 2.89 historical cohort, the newer data in the contemporary cohort, femoral complication are 4.69%, almost 2% higher than what we had many years ago. And of course, the radial was 1.42%. So that is true, radial has a lower, but key is that because of the radial adoption, now we are having a higher femoral vascular complication. Not to say higher MACE rate as has been shown in the matrix trial in the radial labs. And therefore, this they go to, these are various bar graphs, but basically self-explanatory. Historical cohort, which was all femoral, and the femoral contemporary cohort, clearly you can see big difference. And then they will see that difference is both for cath as well as PCI. You say, well, maybe it's part because the PCI are different now. No, that's not true, because you see the difference even in the diagnostic cath cases. So diagnostic cath, you go to the vascular complication for femoral, much higher otherwise. Now, other thing which they also did very smartly, two analysis they did. One was that what are the, based on the vascular risk score, so that patients who should have a higher vascular complication, there is a clearly lot of risk scores are available. So they found that if the cases where the vascular risk score is in the lowest quartile has the highest vascular complication. So this is the basically attributable risk versus what basically noted. So clearly, the patient who should have low vascular complication had a higher vascular complication in this study. Same thing, the propensity of changing of the femoral access, that means that basically higher complication were noted, which is the patient would have gone for the femoral approach. Simple, not taking that these are the complex cases. Simpler cases had a higher femoral complication in the radial era. So this is the very important message which came out, that clearly that this is a paradox which we need to understand little more, but has come up that high radial centers, little higher MACE rate in the matrix trial, higher vascular complication in the matrix trial, higher vascular complication in this latest paper, and they give the various regions. It's not a chance finding, it is truly higher vascular complications for possible regions, and both for the diagnostic as well as for the therapeutic intervention. So what should you do? Recommendation to minimize the radial paradox. One is improve femoral access by use of fluoroscopy, ultrasound, micropuncture technique. So what has happened, that now with the radial, everybody concentrating on the radial, nobody teaching the femoral techniques. So we have to go back to the basic. So even if you are radial operator, you still need to learn the good femoral access. By you can enhance by your putting where you are going to puncture, ultrasound, micropuncture, use of bivalvuline, which we know decrease the vascular complication. with properly trained vascular closure device use, and more important is that which has been shown that in the radial cases give you full anticoagulation only after you engage the coronary artery. If not, if you have to puncture on the full anticoagulation, if you cross over, you will have a higher vascular complication. Very, very important point. So, basically continuous education of young interventionalists in femoral access technique with formal teaching, training on simulators and maintaining a minimum femoral access procedural volume are mandatory to decrease this radial paradox. Key is now nobody talks about simulator for the radial, I mean for the femoral, they all teach the radial, but you have forgotten femoral. Clearly this is associated with higher femoral complications. Now in the rival trial there was some trend, although MACE was not different, but remember rival trial the centers were equally proficient selected based on the femoral and radial, so compared to the matrix trial, and that was one of the controversial and the latter which was noted and so. Now it does happen that we put all the trials that clearly the radial is beneficial as again on the patient level, and that has led to the guidelines as you know 2A for the ACC, and then now they have upgraded for European Society as a class 1B patients with the STEMI. So yes, the radial is good, but don't become just pure radial fanatic, because you still need to learn the femoral. In appropriate cases you have this selection. So second quick point, changing predictors of the CTO. Now this is the Toast GC trial from Italy, where used to be the various predictors in terms of the length, calcification, duration, multivessel disease, and bridge collaterals and stump morphology. Now which has come up with the new predictors in first time CTO success rate. The overall in this patient of age 1657, success rate was 72.5%. What they did is they made a scoring model in first 1100 patients and applied to next 500 patients. And basically what did they find? That overall that these are the 6 factors. Severe calcification has the highest odd ratio of failure than previous CABG, lesion length more than 20 millimeter, previous MI, blunt stump, and non-LAD CTO. See, all these except the last one non-LAD CTO, all 4 severe calcification, lesion length more than 20, previous MI likely in this case, and blunt stump, all are unfavorable of today's CTO recanalization. Most important being the calcification, which we have emphasized in last few years, that calcium is the most important negative predictor of success of the CTO. And they came up with the based on the score that clearly that if you have lower score, you have a higher success rate in both validation, derivation as well as validation. So key makes sense that simple lesion based and clinical based score can give you the success. So clearly if you have a class 3, your score is more than 5, that probably should not be tried because they have a higher complication. Many of these patients done with a retrograde approach. Clearly for the bypass patient, it has been shown that if you work on the native vessel without bypass or native vessel with bypass, the success rate is very different, 80% versus 70%. So clearly this has been the factor. So now the last one, while we are getting ready for, there is another piece of data of the first randomized kind of look into that what is going to happen when we do a CTO PCI as such, because there are the 3 trials ongoing, one of them being Explore, which really presented the data in the TCT in patients with post-MI, that whether you do a CTO PCI or leave it alone. And basically what they did is they looked into the various LV parameters in terms of LVEF and LVEDP at 4 months by MRI, and 280 plus cases, and basically found that clearly the CTO PCI or no CTO PCI, there was no change in LV ejection fraction. So same also, there was no change in the LVEDP in the 2 groups. So seems to be that at present, even your recanalization of your CTO in a short term of 4 months did not make any difference in the LV function point of view. Whether it will do it on the which is the primary endpoint of the trial, and that is the 2 year of a MACE, which need to be seen. So with that note, I think we are ready to do our the CTO at present.
Samin, excellent review. As we proceed with the case, I have many follow-up questions for you.
Sure. Okay, and tell us what you are doing now.
I'm just, we have a fine cross, and this is the fielder wire. We are at the proximal cap, and I am trying to see if the just the fielder can go as much as possible.
So, Anu, would you even ever consider this as a radial case?
After all that he said,
Yeah,
me personally no.
Yeah, okay.
I still think a radial case means radiation wise it's big. Nobody is talking a lot about that, but I think
No, we
during
talked
the last month we did discuss about that.
But what about the complexity? That's the key.
Yeah.
Well, the most stunning revelation.
Don't get me started with radial. Let me finish this.
No,
case.
no, I don't want to. I mean, when I walked in here, I announced we are going to have a long case. So
Yeah. No, but more important, Samir, the key is that this is the first time these things have come to the real discussion. Nobody talked about this until recently with multiple letters in the Lancet about the data of the matrix trial, that higher event rate in the high radial center. I mean, now you can say there are a lot of discussion about is it because they were the teaching centers. So maybe fellows causing more complication. So whatever the reasons are, it clearly was just beyond which can be explained in a simple way. So it was really I would say that forgotten femoral.
Look,
the complication occurred because of forgotten femoral approach.
The most puzzling fact of that is it's kind of counterintuitive that you normally felt that it's a higher center which should be having the lower complications.
That is correct. So this is just amazing, just very, very interesting. So that I just say, I think this will be little sober. These data will be I call it the newer breed of radial interventionalist. So all younger people, they feel like that by doing the radial, they're doing the state of the art, the procedural technique. So they are the master compared to old, which we are not adopted, and so forth. But clearly that this has to go beyond just the radial teaching. So that don't ignore what your basic is, and that is the femoral skills.
And it almost seems as if there is a sense of being casual about the femoral procedure. That,
absolutely.
And people have forgotten the importance of mastering it.
It just doesn't stay there. You want to get anyway, have a no torque ready. If this keeps coming out, you need a no torque. Okay, come back. We are in the septal.
Yeah.
So you want to take up, clearly that is the vessel is going on the top.
Okay. Now this is the time you change. If it's just going to the side branch, the fielder is not the wire to get into the proximal cap. So we are changing it to Gaia. I think what Gaia has done is that it is essentially replaced the Miracle Brothers.
I'm actually quite surprised. I know that you have liked this wire, but to quickly move into that, I'm sure you've had numerous cases where you found it very useful. Sameen,
no, I think this is the thing about CTO now. What they learn from us is if the wire works, it will work in the first
right. Otherwise,
second.
proceed
if it does
quickly.
Not keep moving.
No.
There's no need to just waste time using the same wire. It's not going to do the job.
Sameen, I thought the best teaching point of your presentation was the delayed anticoagulation initiation after getting radial access.
Absolutely. I think what we should do is
you want to give a no torque cases?
Yeah, we give usually 5,000 of the heparin,
right.
but key is that unless you knew that this patient has a radial before, otherwise just give 2,000.
Right.
And once you engage the coronary, then you give remainder of your 3,000.
So don't jump into full dose immediately after getting access.
Yeah, absolutely. In an unknown patient.
Right.
Those who are not known radial case.
So before you started this patient, what kind of a feedback did you give to the attending and to the patient in terms of success rates?
Oh, this guy, we should told them 80%.
Okay.
Some die here.
Yeah. So they're clearly not our usual 90+%.
Right.
Yeah.
Just cautious optimism that it's a difficult case. And Sameen, the results of Explore are something like what OAT trial told us 10 years ago.
I know, but believe me, that is what really the worrisome little bit and concerning. But I hope that the data are that at least from the death MI point of view, they will stand on their own once we have the long term follow up. But you are right, at least it does not change the cavity and LV parameters. But remember, what happened is these are the post MI patients. Although there were data from Klassen and other group that yes, in post MI patients, if you have CTO versus non CTO, your differential outcome, because patients with the CTO you don't improve the ejection fraction and so, but here it does not, that does not translated in this EXPLORE trial for short term, because there is exactly identical ejection fraction remain in both the groups. But again, this 140 patients, the whether this will be a different in once you start doing a large number of patients, it still need to be seen.
Right.
You have to give me a note torque.
Yeah, I think
the RC keeps coming out.
the right we are going to change, because every time it is coming
Keeps
out, and part
out.
of that is, yeah, take it out, yeah, is a little anterior takeoff, and it's not a long sheath. There are two regions while the right has been coming off. Yeah.
You want the long sheet? We can change it if you want.
But let's say if the noto can fit. You want to change the long sheet now? 5 French?
5 French long
Yeah,
sheet.
let's do it. Yeah, because this case, or you want to put a 6 French in case you go to retrograde.
You can close the groin? Okay, give 6 French then.
Yeah. Then give us a long 6 French sheet. So what we are going to do now, you want to just go with the guide then?
Too much dye.
Okay. So we are going to change the sheath on other side and the catheter. Just to give, remember we say the long sheath basically gives you almost 1 French higher. The 5 French becomes 6 French because the amount of support it gives you. So that is our usual, and this is the classical case. Every few times you are moving the catheter and the catheter coming off. So that we are going to do now using a long sheath on the left side also.
Okay, ready?
Yep.
Yeah, take this out. Then you have the no torque, 5 French. 5 French no torque.
Yeah,
Okay, don't
5
use the
French
6
we have.
French.
Yep. Yeah. Samir, you had said there are some questions while we are changing the
yes,
sheet. Yeah.
I'll mention about that. In the meantime, some questions have come from the audience. They are kind of mixed, but the sense of this is that what is the basic, absolutely the basic equipment, including the wires, lab should have if it is not a terribly busy CTO center?
I think the basic wires that they should have over the wire, which should be fine cross, or if they don't want to have fine cross, maybe even the 1.5 balloon, the over the wire 1.5 balloon that we get, the Maverick, and
Of course, the Corsair would be an absolute basic.
Absolutely.
Yeah.
Once you are planning retrograde,
Right.
yes.
that's one. And fielder, though we don't, a
Which-
lot of
which-
people
which
like
of the
fielder.
fielders?
Yeah, regular fielder and fielder XT.
Okay.
And I think Gaia wire is making a big impact everywhere. You can have, if you want, they have Gaia 1, 2, 3. We only have 2 and 3. So I think if you want to keep one wire, keep Gaia 3.
And,
And
what
then of course the Confianza.
Confianza, okay. That so we've got 20 centers already online, and please continue asking any questions, any suggestions, recommendations.
Good, thank you.
So, what is the percentage of radial
No.
cases being done at Mount Sinai at the moment?
We actually have to look into it. The diagnostic is already 20 plus.
Okay.
And the intervention may still be about in the 14-15% range. And the part of the diagnostic is that patient with the low risk case, we are just going with the radial, is easy point of view in terms of post procedure discharge and so on and so forth.
Well,
Yeah.
I was
But
about-
definitely has increased. We need to know the latest one in the United States. It's about 16%. So we are probably in line with the ACC and CDR. In acute MI, yes, definitely has gone, because that's where I think real benefit is. Patient with acute coronary syndrome, there in the country is about 31%, but overall, it's the last report of the 2015 early was 16% radial interventions being done in the United States.
Right.
Now,
But I think the real balance, in my opinion, will be around 40%. I think that once you get to the 40%, that's probably the reasonable number.
some dye on the RCA.
This in one of the septal.
Again, it's not coming back.
Let's take a picture. Is that the septal or that's
Yeah,
the diagonal?
septal, which one?
Where your wire was.
Septal, I think.
Let's take a good picture.
RCA still is not engaged.
No, this is okay now.
I think I'm in the septal.
Let's take a picture. So I think we should take a picture.
Definitely a little more promising direction than where you were the first time, although I still think we are in some small septal, no?
Same thing, you advance your fine cross and then try to lift it up. You want to bring that picture up now?
Now, okay, no. Now RCA.
I almost get a feeling as if although the previous JR catheter was bobbing around, this isn't doing too much better a job.
I know.
But at
some
least
dye.
it's there.
Yeah,
it's
it's
right.
Yeah, at least it's not.
Let's take
Samin, we had a fantastic Lumen Global STEMI meeting attended by almost 1,000 physicians in Kuala Lumpur, Malaysia.
Fantastic. Congratulations for a great global advancing the STEMI field globally.
Well,
you and Lumen has done a tremendous job.
The more there are some astounding facts there. The first part was that who could have believed that a STEMI standalone meeting could be so successful, and then the amazing part is that in numerous parts of the that is looking very promising there.
Yeah.
I think you are through.
Yep. This is the Gaia,
and
and of course the technique,
Don't-
but the
don't-
wire
the
is the
skills, yes, and
wire
the skills,
of the various wires. Yeah.
Oh, no.
yeah, but
No, it's somewhere.
no, somewhere else.
Come
yes.
out from there at that level.
I think probably not.
Premature celebrations.
I know.
And Samin, the other amazing part is that in some parts of the world, STEMI is probably becoming close to number 1 or 2 indication. That surprised us.
Yes.
Maybe we are in the wrong channel there.
Right. So the question
to
is,
put
did you
LVEF
go into the wrong channel very high up proximally, or?
I think so. Get me a miracle, confianza. Maybe we have to
Probably also come back with the
yeah.
support catheter. It's maybe already in the.
You have the confianza?
Anu, almost 100% of your CTOs in the last year or two, you've started with the antegrade approach?
Yeah. I mean, unless, remember, there have been osteal
Right,
LAD, osteal
exactly.
RCA,
Yeah.
and they have been sent from elsewhere to us. Those kind of cases will do retrograde to start
Right.
with. There are very few of those where we know will be retrograde. You took the wire out? Oh, yeah. Okay.
So you're on to the confianza now?
Yeah, I think what I'm going to do is get the fine cross back and
Right. Start probing
pierce the
there
cap
again.
at
Yeah.
a different level again.
Yeah.
I think we are in some kind of a small septal here. Oh, and go to the same thing. Okay.
Slightly different course there, right about there.
This RCA is same catheter is
This
Struggling,
RCA
yeah.
is good. RCA is good. Inject.
okay.
RCA is good. No, RCA catheter is nice.
No, see,
No, it's not. Okay.
Jumped out.
So you want to just go with the implants then?
I think so. Diagnostic, right? Some okay, now we are in maybe. Some. Now you are in. Uh-oh.
No. Okay.
Good. Okay.
AR2
Okay.
diagnostic.
I think here it's giving a false impression that we are in the loom.
Right, right.
No. I'm going back to the caudal view.
So we
Some dye?
continue in the recording studios behind, we continue to have the cleaning lady paradox. We close the room to everybody, but somehow housekeeping manages exactly at this time. So the best laid out plans, like in CTOs, don't work. Yeah,
Go to this view actually which we had earlier.
right. My only appreciation of this view is how much that wire is.
I think we will be okay here. No?
You need to go to maybe
Before I
aleocranium.
want.
Aleocranium. Because until there, it seems to be because antegrade
Right.
you are feeling more. That means you are in the right direction. Now at the last minute you are somewhere parallel.
Okay. Yeah. Oh, can we have a better RC injection?
Good. We have the AR2. You want to get that? We are ready with the AR2. But key that remember in the over last few years, if you those who have attended our the webcast, I always have emphasized the calcium
Right.
is the most important predictor of failure. And this is where the whole question comes. Of course, the stump and length and those are there, and of course now the prior cabbage and the recent data have really confirmed that the calcium has the highest odd ratio of failure. So I think we
Okay,
should
now?
take a picture of the right side now.
Okay.
Just take a picture. Without that, we don't see.
I want to change the wire maybe. We just have to get into the probably give me a new
Gaia 2 or
Confianza-
Gaia 3?
No, Confianza 12 now.
And the other thing which I always say on the radial point, that we learned that more radiation. The second issue is that if you are having unsuccessful with the radial, there is nothing wrong going into femoral. So you can quit little early, but yes, the key is that yes, once your plan was radial, you try right, and if not left radial, but that's it. So, but you know,
Samin,
don't waste half a day. Yeah.
I think you are exactly right with that very pragmatic observation, although more recently I have been surprised at the resurgence of there it almost looks as if you are in the right place in the ulnar. That has surprised me.
Yeah, that's right.
A lot of ulnar access.
I think they say anatomically ulnar is a larger vessel.
Right, larger, and you know, so that may surprise us how much penetration there is.
Yeah, actually the original data when he published of 100 cases, the Campau
Give me
in
one.
in
Canada.
CCI, Canada, that they
Oh, you
had a
took it out?
failure rate of about 12%, and the 2% they could not, you know, could not advance the catheter in 12%, and 2% could not engage the coronaries. So it's still that time. So now I think that number has gone down to about 5 to 6% on an average. So over last 20 plus year to 20, actually 30 years, we have made headway that number has gone down to about half. So most of the trials, the crossover rate is about 5 to 6%.
We are just changing it to now confidence at 12. This wire, this other wire out. Still very.
Same, just a very small tips.
So, I mean, when you're proctoring and doing a lot of cases outside the country, what is happening more, CTOs or left mains?
The left main and acute coronary syndrome. That's right. But left main.
Yeah.
CTOs are not tried that much.
Some die. I'm pulling back the fine cross a little bit.
Right.
Yeah, now die. You want to change it to AR2?
No, don't move
So,
the head.
Yeah, very deceptive in that view to. It's again.
I think you go with the new Gaia now,
Gaia?
Gaia 3.
You have to make no, if you have to. No? No.
So the Gaia 1, 2, and 3 something like the Miracle Brothers with more difference in the density of the wire.
Yeah, same, the tip
Stiffer
of strength.
tip,
Yeah,
yeah.
that's right. Question, do you want to think about the
Retrograde?
Yeah.
This is exactly what one of the viewers had said, that question mark, time to consider retrograde.
Yeah. I think now you try the new Gaia 3,
Gayatri is not going to make it.
the tip wise.
Mm.
AL.75 guide.
Okay. Too much dye use.
The tip is too big.
Yeah. It's just
Yeah.
you
So,
cannot get a
what
small
do you
dye.
want to change the new wire to?
Get me the Progress 200.
Okay, Progress 200. Actually, Progress 200,
Yeah,
I would
good,
say the
good.
single indication in a calcific lesion to
Right.
pierce that calcium
Yeah.
is the Progress 200 XT. 200 T with a tip of 0.010.
Some antigrade dye here.
And even although that first septal looked good, it's not the best, is it?
No, and then key, the many some studies have shown that if you have a side branch originating at the site of your total occlusion,
Right.
besides having the blunt stump, which is associated with the failure rate.
Right.
So every time your wire will go into that small branch. And people have left a small balloon into the side branch to deflect the wire off.
Yeah.
This is a slightly different approach.
I don't know.
Track.
Same. Some dye.
So, I mean, even at Mount Sinai, as you would have reviewed the data for the last year, have you had a more increase in the ACS patients?
We actually slight increase.
Right.
Because the key is
It's a
that
very big referral center.
yeah,
So you
because
must be
of
getting
more elective
complex.
patients are referred, the doctors bring their cases, and definitely the acute MI, which is barely 2 or 3 cases a month. You say, well, how can that be? Such a great center, you do such a large intervention, your MI rate from the Mount Sinai itself is 3. Well, very simple. The Manhattan, the New York, everybody, they have their cardiologist,
Right.
good
Primary
care, so
PCI
don't develop with a
centers.
STEMI. Yeah.
Right.
They don't develop a STEMI, and this is, I would say, the same. That STEMI is the neglected disease of the physician and the patient. So you can develop CAD, which is a different story, but once you develop a STEMI, means either the physician has not done the good job or the patient has not done the good job. So that is the result of the STEMI, because that's a classical example. So we have our referring center, Mount Sinai Hospital Queens, which is 1/4 in terms of the patient populations, of visits, and so on and so forth, and we get about 12 to 15 STEMIs from them per month. So key is that non-STEMI and STEMI together. So key remains that it's really that if you take
Yeah,
care,
dye.
the chances that you'll have acute STEMI is much lower compared to not taking care of yourself. And that may be the example, the reason why we have such a low STEMI rate at the Mount Sinai proper.
Okay, you have the go with the RCAL 0.75 then, retrograde.
Yeah, so that if you want to try progress, then we'll change the guide on the right.
So, Anu, at this stage, how much dye has the patient
Yeah,
received?
it's a lot here. Because the RCA, remember
was
every
difficult
time is
yes,
like,
yes, you were not. I think more dye went into the RCA
Yeah.
than.
some here, no antigrade a little bit. Is that the right?
Yeah.
Okay, so
Your wire has come back a little
inject.
bit, that's okay.
No, I know.
Okay.
Inject the right so we know. See?
Very
We are in
difficult
the
to make
wrong,
out.
No?
Hmm?
Antigrade, I think our catheter is in the wrong place. See that?
So far it's okay, right?
No.
Let's go to epicrania. Why?
No, it's wrong. Now antigrade dye. Oh.
Little perf.
Think there's a little dissection there, or
And minor perf,
yeah.
Wire perf.
wire perf. So let's stop the angiomat. Let's wait.
Wire. 1 mm. 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 What is he saying?
So this would be, you would classify this as a micro.
Yeah, I mean clearly, of course, you need to see it does not extend,
Integrate
Right.
little
but
bit.
immediately we stop the angiomax in those cases. If need to be, you close with the balloon, and you have to give it a gap a little bit anyway. Right now, no more puncture. Meanwhile, if you need to decide, you do a retrograde. I take this out from the fur.
But still, I think it's
Well, that dye stain is staying.
Yeah.
some dye here.
Antigrade?
Mhm.
Okay.
Okay, retrograde, do you want to go with the AL.75?
Yeah. Yep.
Who's having pain? Want to go with the guide only
Yeah.
for the
For the
retrograde.
retrograde, yeah. We have AL.75 ready. Antigrade, retrograde, you want to say?
I think this has gone to the wrong. Give me the AL.75. What was the ACT? 310.
And what you do is you stop your angiomax for 15-20 minutes. Usually that cloud should disappear, but if it continues, then you have to interrupt your intervention.
Usually it stops.
Pain is gone, okay.
Get me the. Yeah, Corsair, which Corsair? Huh? Yeah. We have the regular fielder, right? Let me use that first.
You have the floor.
This should be extremely instructional to the viewers here. The decisions to how you manage, how you monitor, how you watch that, and instinctively, I think most relatively less experienced operators would immediately stop. But okay, this catheter is definitely a much better choice.
Low mag or?
No, so we see exactly where the septal is, right?
Yeah.
You want to try here now again? The
No, retrograde.
yeah, I know.
Yeah. I'm giving injection with the RCA to see which branches. Do you want to think about the apical one or no? If there's not much tortuosity, let me go.
I don't know if the
for-
devices will reach there.
No, with 150. Yeah, let's see fluoro. Try to see the apex. We'll just concentrate on the apex.
No, I think septal is okay.
Yeah, no, but just 1 second. Go, Sene. And then we have choices, whichever you feel like. Yeah, septal has to, because the very curly Q.
Okay, give me the Corsair regular fielder.
So, I mean, from the last picture that The blush there, you're not concerned about it, you think?
Oh, this one which is in LED?
Yeah,
No, no,
okay,
that's nothing. We call it a smoke.
right,
It will disappear.
okay.
Yeah, this is just a wire that has caused some. Okay, take that out. Good. So we are going with the Corsair.
Right.
Actually, Corsair comes in two length. One is 150 centimeter, other 130. So
Which
if
one
you are
are you
using
using?
Corsair, no, this is 150 you need for retrograde.
Right,
If you are using Corsair for
anti-grade. Then you
anti-grade
can use the smaller.
or anything else, you can just use the one, because there's a big difference in the cost also.
Hmm.
So you have to be very clear which Corsair you are keeping in the lab, and ask for the right length. They are different color also. So same, you go with the fielder wire first. Am I in the PDA now? Yeah, so I just want to give dye. Let me go LAO, check that I'm in the PDA. Hold on. Probably not. Okay, now dye. Go to the PDA. Big PDA here. This is a regular fielder.
Mhm.
Now you go to the RAO view. Now let's go here. Same view. Some dye. At least you are in the right septal. I think what you do is bring your Corsair to that septal and take out your wire and make a different curve. Give me the fielder FC if you have. The tip load for the fielder FC is different, lower, so it's better to go through the Corsair, to go through the septals. Soft tip. Or we can even have a whisper many times.
Right.
So I'm changing so that it's more of an
Modifying the tip at all.
yeah, tip. So this is another step which many people would do, that you inject through the Corsair at this point to make sure you're in the right septal and understand, the septal blush and select a septal from there, which you have seen. I don't do it most of the time. So if you go back here, going to the wrong septal there. Okay, now. Yeah. Here that other, they have the Cheyenne, right? Not the Cheyenne. Some dye.
So, I mean, how are you logistically doing with, let's say you have 2 or 3 CTOs, do you bring them on a certain day or?
We try to, usually on Tuesdays.
Yeah, because this imparts
But
a lot of
the same,
logistical.
what I meant is I would not book more than 3 on a day.
Right.
Because we have 2 rooms today, we have towers.
Absolutely. I mean, this is
Today we have
logistically.
4.
Right.
3 of mine, 1 of his. So not more than that. Some die. Oh. LV. Okay, now die. Looks like they are subtle to subtle connection, but the wire just does not make any turn
Right.
there. So we try a different subtle now. You get a lot of PVCs, which is not a good sign, but still, you know, you can poke a little bit to see if the wire can find a channel there. It's LV cavity.
And again, you determine that with the PVCs there or just the
No, the way
direction
the
of
wire,
the,
the wire was
moving,
very free.
right?
Free
Yes,
floating
and
wire, yeah.
Some die.
Yeah, that's clearly a different direction this time.
But this is not the subtle that we want, I think.
Yeah.
Go up. You want to give some dye, see before we go up with the
Antigrade.
dilator? No, 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 retrograde only. Retrograde means RCA. Okay, that was what it is.
Looks very
Yeah, good.
very good there.
But you see how the wire went?
yeah.
So that is what we say, if you are in the right septal, the
It'll
wire
seek
will find immediately.
right,
Yeah,
right.
you don't have to, waste a lot of
It's a
time.
very good.
But the point
teaching
is,
point.
you see that the entrance where we are reaching, that's where we were there
With the
earlier.
antigrade, with the
antigrade, and
right.
that's where the
Yeah,
still
but now
issue will
this
come.
This
Yeah.
is not making a turn.
Anu, so have you at this stage restarted the bivalirudin?
Yeah,
Okay.
we are almost, you see that the smoke is still
Yeah, it's-
there, but
yeah,
the smoke
it's-
is nothing
it's-
to do
it's
with
diminishing,
the,
yeah.
Because now we are,
So that smoke or the micro perforation to put in a balloon tamponade would have been a complete overreach.
that is definite. Now this is, you got to remember, we are using Angiomax, where I am sure 99% of the people will not use Angiomax for CTO.
Right.
Most people will use heparin. So,
With the sense that you can reverse it.
with a sense that you can reverse it. But I think you see what we do, we use Angiomax, and I can tell you,
Well,
you
the
stop
very
a little
short
bit, you stop.
half-life, yeah,
short
the very
half-life.
half.
You stop it for 10 minutes, your back to ACT goes down, then you restart. Without bolus, just a drip.
You had a chance to use Cangrelor
Now we are used only as a bridge
as
so
a bridge
far.
for surgery.
Yeah, we are still
Right.
waiting for our pharmacy,
yeah.
the PNT committee approval.
This is not going.
Yeah, because it's such a small branch. The question is, does it go through the main branch? You see that C minus, if you see, you're going through the small branch into this
And
major
then it's a
septum.
septal, yeah.
Yeah.
No sense putting in a very small balloon there?
No, that's what is the next step before you become See,
Yeah.
the one thing about becoming aggressive there, you definitely can perforate the
Yeah,
septal and
yeah.
septal hematoma.
Yeah.
That's for sure. unless you know that you are in a big septal,
Yeah, yeah.
like the major septal that we saw, where you know there is some kind of a tortuosity that is not letting this corsair go.
Excellent, excellent teaching point.
What we are teaching is where we are concerned. If we are concerned means other people should be super concerned.
Now you want to see the wire in the antegrade direction?
Yeah, that's what
how
I'm
much?
trying to see, if I can get this go all the way and see where we are. Antegrade some die. Oh.
Well, the only thing the antegrade does is create more confusion.
And also I think the guide is coming out now.
Yeah.
I thought it's sitting good. Okay. You want to check cranial and see how where this antegrade wire is?
Sure. Give the antegrade injection.
Yeah, okay, let's go see now. Aye. We are in a different area completely. Okay. Antegrade injection only. Okay. Oh, you want to give retrograde also, SS, so we
Yeah,
understand?
Okay. In this one, you give antegrade first.
Go.
No. That definitely create a lot of confusion. Nothing.
Yeah,
unusual.
yeah, very.
But my only question is how is it going to help? Because you were there earlier until that point. It was the outward going point is the one which we need to do.
See, even the retrograde, I'm not sure where.
Let's say if you really go all the way into, can we advance a little more wire? No, not at all, right?
Oh, this one?
Yeah.
Unless I change the wire now to a little stiffer wire. If I can get the corsair up a little bit. Give me miracle 6 maybe. It's in a, it went through such a small septal.
So the choice for the miracle would be to give you more.
No, I'm seeing if
Tip,
I can,
yeah.
you know, be almost there. If we went retrograde and we now have to reach the proximal cap of the osteal LAD, and if
Right, you need
if
more.
we can get the wire there, then we can balloon trap that wire and hope the corsair will go up. Because right now I don't have good guide support of the RCA. RCA guide is coming out. See, corsair is trying to go up. I need a little bit more. It has made a little turn now. You see that? Turn into the septal there. Now, how far are we into the LAD? Antegrade.
Well, the corsair has moved there. Or is it that the guide has backed out?
See how the RCA guide keeps coming back. Okay, I think we change your miracle. Okay, good.
You know, in the morning when I walked into the room, I'm glad I told this crew, I said, get yourself a large coffee. We are in for a long case.
Now antegrade either.
Tactile, are you feeling a different sense with
This
this?
sensation is different.
Yeah.
Lot of resistance.
Yeah.
Now die in the
Antegrade.
left main. Maybe in the left main or no, we don't know because it's such a huge.
Probably not.
Now die.
The Corsair has advanced so much further, but
By itself.
Yeah, by
no, but this is a different view, so we don't know.
even then I think even I get a feeling it's, but you know, we'll see.
What is happening, he's saying? Pain or what? He's very restless now. Okay. Let's inject to the left main. I'm going cine. Antegrade.
What do you think?
We could be there, but same. The left
Not-
main is
not.
so big, getting into the guide.
So the feedback I have here watching the audience response is that your audience doubled as soon as you went retrograde.
You want to take up alone, some die here in the antegrade now. What is he saying? PP? Trying to. Other thing is I could take up alone even if it's in the proximal LAD, so some dye here, so I can trap it here. It does not look like we are there. No? Okay, let's go see then, okay?
Not sure, huh?
No need for dye, yeah. Usually retrograde, you should not have this much trouble. Like
Yeah,
if you are in
yeah.
the right lumen, you should
I-
be able
I-
to get, huh?
I just thought that, you know, it's just that septal there, it has gone into some different branch or something, and it doesn't really behave, but
Okay, some dye.
yeah, feels different there. No, maybe not.
No, okay. We just have to be in the multiple views to make sure that
Yeah,
it is the LAD,
exact-
there,
exactly.
hostile LAD. Okay.
Not sure, not sure.
Could be.
I mean, just at the latter part of the injection, you have
Give
a
me a-
feeling it's somewhere else.
2.5 balloon. Yeah. You have? Angiomax is going, right? 2.512? Tell him uncross the leg. Okay, get the indif. You prep the balloon? Okay, you give me a fielder then. I'm just trying to see if I can trap it going into the LED. Now we think it's in the LED or different views. See that?
Okay.
What do you think?
Yeah. Yes. Looks that way.
We have to go to different views. Give me a filter. So now I'm going to, if we think, what I'll do is I'll wire antigrade LED, see as much as we go, and then
Put a balloon there.
balloon anchor this
Right.
wire and see if the corsair will come up.
Yep.
Because it's very difficult in that left main to get this wire get into the give me
Into
the-
that guide catheter.
Yeah. Huh? Oh, yeah.
I mean, we have some time here to discuss some other matters. What's the progress with BVS?
Well, I think they still expectation from their point of view is April, and of course they are trying to make it a very big issue in terms of the various technique issue, because remember that every trial has shown 1% higher thrombosis.
Yeah.
So now people are, there is a lot of controversy will occur.
1% very late thrombosis.
Yeah, I mean overall compared to your DES like Zions and so 1% higher stent thrombosis, and it seems to be
related to the technique.
Yeah, technique, and so it seems to be that maybe if you do a more imaging, that number may go down, and
Right.
that idea is that that's how the Japan and so there is no difference in stent thrombosis of the BVS. So key still remain that you need to change your techniques and so, and that's where will be the big concern.
With better lesion and vessel preparation.
Exactly. And while we have limited data on that, I mean, key is that remember the complex cases. Once the BVS is approved, people will use it for complex cases like calcific, where we don't have any data at present, but that's where it will be used. And I think this may, in my opinion, will be a synergistic. So this will be a synergistic anyway.
Okay, give me the 2.5 balloon.
Okay, 2.5 balloon to compliant.
The way this two are parallel to each other looks like it is the LED there.
Yeah.
So what I am going to do, we go with the 2.5 balloon on the fielder wire, which is in the going through the left main, anchor this wire and see if the Corsair will advance more. Then maybe we can get a change in wire strategy to get into the.
But I still think that even after we get, we'll have some issue. And the issue basically will be that you are in that mid LED portion where you still have to make a turn.
No, that way, go up.
Yeah, go.
No, I think after that should be okay then.
Now let's go to this one now. Go with this technique. Because that's where you were earlier and you needed to make that outward curve. See? That's where, but anyway, at least we'll get you up to there.
Okay, good.
Yep. You want to low mag or you're okay?
Look at the RCA guide, it's just not giving us any support.
Is the Corsair moving or the
Corsair
guide
is
backing up?
Both. Both happening.
Yeah.
But definitely Corsair moving, yes.
Corsair movement has to be the same. Back foot forward. Okay, good.
Now your wire still came back.
Oh, the Corsair.
Yeah. Okay. So
At least
now
we have some
basically-
more improvement.
Yeah.
Okay, so deflate
Deflate
that
the
other
balloon.
balloon.
Yep, we are going to deflating it.
Uh-oh, what happened here? Take out.
Open to the guide.
Yeah, some light.
Become too long.
Yeah, waiting there for a long time.
This was the 3.5 guide earlier. Yeah, you need another 3.5. Became too big. Yeah.
Nothing changed. We're just changing the guide from the left side.
Right.
3.5.
The same 3.5, yeah. Because the 3.5 now being so long inside has become 4.5 even.
Give me the wire. Good.
You've had instances where the fellows were able to do the retrograde case themselves?
Not in the training, but
Right.
after training we have
No,
few of them
I
have
meant
done
during
it.
training. I meant
No,
during.
Not
no,
during the
yeah.
training, you know.
Antegrade
Of course,
by
yes,
I
yeah.
mean by the
Just the
second
wire.
half of the last day doing it.
Right.
Yes. Okay.
Get that fielder wire again, maybe if we need to go.
Now you want me to go to the fielder? Question now, it's in the, you want to change to fielder wire here through the
Corsair. Hmm.
Now what about the, you bring the guide up to the ostium.
of the LED.
Yeah. Ostium the lid. Good. Now see, pull back the wire and try to rotate again. Good.
It's, I may have to change to, you're right, okay. You have to understand the left main, almost 6-0. Some anti-grade dye there. You have to try
You know,
that
till
again
it
and get
gets
the, huh?
till it gets into the left main, it looks so promising there.
Yeah.
Unless you get maybe change to run through SS.
Yeah. Just do
Get
the
a run through.
Give us the exchange length run through.
No. Exchange length run through will not be that easy to manipulate, no? Why you need exchange length? Give me a regular
No, we'll
180.
be okay. We'll be okay. Let's take it up.
No.
Help out, yeah. Take this wire out.
Like this. It's not, manipulation is not that easy with 300 wires. We're trying now to see if we can get into the,
Yeah, the way it went for a moment, it
Yeah, we
looked
thought
just
it
too
did.
easy, just too easy, huh?
Let me try. Hold it, hold it. 1 second. Off fluoro. Release. Go integrate.
not that easy.
Okay, so the guide may not be the good position.
No, it is.
You have to pull back a little bit. I thought maybe advancing will be
here
helpful.
I did. Unless you want to take FCL, so it focuses into the LED.
Look for FCL4 also.
Ask him to take a deep breath. Respira profundo.
Okay, respira normal. where is this guide going? Wire.
Some
It's
dye?
not going into
Left
the
main?
left main. Where is it going? It is going in the left main, but without outside the guide. Okay, what I want to do is pull the guide out a little bit. Let's consider the.
You mean
guide out little more.
come
Yeah,
back
good.
a little bit, yeah.
Good. Now little die.
Maybe
Not
the
sure.
subintimal.
Yeah.
Maybe a 70 more.
Okay, get me a confianza now. If you are subintimal, then.
So you
it's
think
no
you've
good,
gone subintimal somewhere right at that
Yeah, at this level.
the
There. Because I'm saying you cannot. Okay, there. Are you in the lumen now? Yeah, now you are in the LED. I mean, left main.
Take a deep breath now.
I'm telling you, let's trap it.
Okay, breathe normally. Okay, tell what we need to.
Get the fielder and the 2.5 balloon again and get the Corsair as much closer. Yeah. No?
Okay.
Corsair is going
the only
further
way.
and go? No? Nothing else?
Yeah, no.
Okay.
Okay, let's get your wire.
Well, this is no good. If the 180 wire would have been better.
Okay. No, but which wire you want now? Retrograde, do we want anything retrograde or no?
Okay, let me see.
So Anu, how do we know that at some stage the Corsair is not subintimal?
No, it may be subintimal as long as you are right. As long as it can pierce and get into your main vessel.
Main channel, yeah, re-entry there.
Which is okay. And remember those reverse cart and so those techniques are based on that you create a subintimal space with a dilatation. So the antegrade you can puncture back.
I think the Corsair has
Actually has come back quite a bit. Here maybe you need a confianza to get into the main lumen.
no, we are in the lumen. Except now, let me better run through, shorter.
Now that we are long, we get a new shorter run through.
Okay, ready?
What?
Which one? Where are you? This one? Only other thing that we could do is dilate the LED through this wire, and then we go integrate.
But which balloon will go?
2012, the mini trek. Get this in the circ now if you want.
That we can do. Your Corsair has already come into the left main.
Some antigrade dye. Okay, get me a short run through.
Through the retrograde, no?
Yeah.
Corsair.
Because the other thing we were thinking, if this does not work, we cannot get it. We try to get the run through into the circ, hopefully through this one, and dilate the LED. I know, we know dye is too much. here,
Question,
but
do
we
you want to
cannot
go
help it.
side by side antegrade and then
I tried,
dilate?
no. Before I did that, I tried, we could not. With the fielder, I tried side by side. Because that's the other thing that now you have, we could do, suppose we get this wire into the left main, take the corsair out, we have created a dilated that LED already,
Yeah.
then you can try side by side
Yeah.
also.
Right.
This is such a big ocean. Okay. Some dye here, we go to the,
And the corsair continues to advance virtually on its own
Yeah.
with the beating, you know.
The
Yeah.
beating. Yeah. As long as beating and
I'm
then
just
keeps going into the
wondering
left
where
main.
would it be at this moment?
Yeah.
I think the only other thing that we didn't try is, my only concern, why this does not fly like it's going to the aorta, no?
Yeah. I mean, case now has to be here. Leave this wire little antegrade and try your retrograde, you know, leave the retrograde wire, pull back the corsair and go side by side antegrade wire.
Mm. Yeah, I know, that's okay.
That always happens, RCA guide is sucked in.
It looks like we are in, does not go in.
Do you want to go fielder antegrade or whisper?
Get the, yeah, we can go whisper.
Give us a whisper wire, please.
You know what my concern is? It is not some dye here.
Yeah, just leave it there.
You don't want to go.
Good. Okay, here's the whisper.
Give me the on the fine cross though.
Although we're going to go antegrade balloon, no?
Huh?
Why fine cross? Why not antegrade balloon?
Antigrade balloon. You want to change the wire?
The corsair has made.
You want to see if there's a channel antigrade by corsair?
I know you came back with the corsair
Yeah, I
because the
did.
guide was being sucked in. Is
No,
that,
no,
or just
because we are trying to see.
redirect?
That can we go antegrade now?
Yeah.
Yeah.
Since we created a channel.
Channel there.
I think.
Hmm.
We need a different view.
Yeah, the only consistent thing in this whole case has been confusion by taking antigrade injections. Absolutely does. You know, each time
Does
I
not
look
do
at it, yeah,
anything.
it doesn't. No, makes it even harder.
Yeah.
The decision making is all skewed.
You want dual injection?
Okay, but all right, go. Antegrade injection first, go.
No, retrograde first, no? Okay, go right, RCA. Okay, go. The only thing is maybe we are antigrade, we are retrograde, we are not in the right channel
Yeah.
process. Hmm?
See that? The channel. See here, if you want, that you have to get in the with the confienza on the top. See, 1 second. See where it comes? There. That's the lumen.
We are talking go in the
Antigrade.
Retrograde.
And
Yeah, no, with the retrograde, but you need a little stiffer wire because the lumen is little above.
To puncture the distal cap.
Yeah.
Now, same thing, no?
So, I mean, during the entire case, I mean, I'm not
Take out this thing
sure at all,
completely.
but any imaging modality may have made any difference, does it, do you think so?
Well, I mean, they always
IVUS.
talk about the CTO.
Right.
The IVUS, I think IVUS is, if you are very expert in IVUS, maybe, but even IVUS people say
Not
the
so.
CTO is a very less
Right.
help. But if the CT that you outline,
Now is hair dye. Do you want to take this thing out completely?
let's take a picture here. Let's
Now.
zoom in. 1 second. Yep. Take a 1 cine. Yeah, he needs on that top one. So bring corsair up there and get a confianza.
But retrograde, if it pierces through, we might still have trouble. Okay, get us the confianza.
9. Could this be the one? 1 second.
Some dye.
Okay.
That's okay. Let's go antigrade. Let's. The only thing, if we are not in the right lumen, even going antigrade now with side by side does not make sense, no?
I would say.
Give me
that
confianza. Let me do the confianza here.
You want to go confianza integrate?
Here, retrograde.
Okay. But you need a corsair a little further up. Confianza may not make the turn.
Let's see, because we want to do it right from the septal area. Okay, take it out. Since we had created antigrade channel, maybe this wire, the retrograde wire also is in that.
That false channel.
Yeah. If this does not go, we will still try or we give up sometime. It's the wrong view. Assess? I think we have to make a decision soon. Sometime. No. Yeah.
Little die.
Yeah. No. No. Okay, here.
Yeah. We are in this good channel now.
We don't know.
good.
It's behaving very, no. So, I hope somebody in the world has figured out whether it's good to have a CTO at the beginning of the day or end of the day.
This is a false.
Yeah. So deceptive there.
Yeah.
Yeah. I think leave this wire here and go integrate now with your whisper wire. You have not tried the whisper integrate.
This is all in the false lumen that we created, antigrade.
You think the Corsair has also reached till there?
Okay, get me the fine cross and
Leave that wire there.
I think if this does not go
Where's the
antigrade
whisper?
now.
We had a whisper earlier.
Okay, give me here. You have the curve?
Yeah.
Where?
That's reasonable curve, you'll see.
What reasonable curve? Nothing. Okay, pull back. Hold the wire. Give me now some dye here, antigrade. It's not making good turn. Some dye antigrade here. Get me the run through wire.
Now it keeps going into some
Small.
ramus or something.
Where's the run through?
I know your stamina and concentration have been admirable.
Thank you.
I mean, it's very,
You got to be physically fit
yeah, also, no,
to
just,
this level of continuously doing this work for so many years.
right.
Not to develop back pain, or most people you see they start hunching like that because they are with the lead whole day.
And I'm a little different. If I don't wear the lead, I develop back pain. So after a few days, I'm traveling and I'm not doing cases somewhere, not wearing lead, I start having trouble.
Young interventionalists who are developing back pain.
So what, you put on lead and get a better sleep?
That's it. I'll be carrying the lead in the suitcase nowadays.
Probably need to come back a little with the guide there, or now it's taking you into the, okay, here we go.
Go integrate a little bit now. You're okay? Okay.
here do we change the wire again? Oh man, yeah, yeah. Let me, we never use progress, right?
You did, but
No, we
long
never,
time.
we called and we never used it.
I thought you had used it, but I may be wrong.
We had it, but we never used
Never used it. Okay.
Good. Now slowly advance your fine cross. Keep it straight. Good.
See again, they are not parallel.
Mhm.
Oh, now maybe. Give me that progress. Let me try progress.
Antegrade through the fine cross.
Antegrade through the fine cross, keep that other wire there.
It will not work.
Huh? Oh,
No, they're trying to see.
okay, take that out.
Now that cloud has decreased, so that it's going to go forward now a little more.
Now good, right?
And we need to go to different view.
Let's see here, it looks as long as it takes us parallel. Cranial view, you mean?
Yeah. So far looking okay. Good. You need to go to antegrade. Yeah, good. 1 second. Lilario or
The same view we had before. What view was that?
RO 30. One we have just RO 30.
34, 35.
Okay. Good. That's good. Okay.
Die, we are in the wrong, I think. Hey, why are you going antegrade? Yeah, retrograde.
That's a more promising now.
You've been here before. Somewhere here we don't get into subintimal. And somewhere are we in the diet or retrograde?
Looks kind of promising there. It's
Have to go, maybe we are still subintimal here.
Let's take a retrograde picture. Cine, no?
No, some die before I go cine.
Is that a whisper wire?
This
this
is the
run through
progress.
progress 200
Okay.
T.
Okay.
We are subintimal, we have to make a,
And my only question was, even you retrograde, you go, will die. This looks a little better.
we have been here before. See?
Yeah, you're exactly right.
Right here.
What about the whisper wire now from there?
How? We are subintimal.
This is no same place,
No, this may be a little different, will die.
same place.
Same. Get me the starter, maybe a starter.
No, I almost have a feeling as if the fine cross is too distal already. That
Yeah,
somewhere
this may be a little better now, right?
No.
same place. Yeah.
Arvind, that diag? Some diag?
Okay, let's still die now.
Get me a new conference at 12, a starter. We try, otherwise we're done here. Okay? This is Gaia.
Conference at 12. Or you want
No.
a Gaia 3 again?
It's never known to.
Yeah. I think let's get a Gaia 3.
So Anu, the real encouraging sign here would be if the two wires are absolutely parallel.
They are.
Yeah. Until
Up
there.
to a
See
point,
that?
yeah, till the
Until there, but
then it
Here
diverges.
we go a lot of subintimal track here. Why don't we try the starter? See if we can pierce it.
okay. You want to start out? That's fine. Let me just give one try with this
Gaia.
Gaia 3. Let's take the wire out. Take the wire out.
Get me the.
Throw away this wire. What wire you want?
Now we're going to try. Brahmastra. Try.
Astrato. But remember,
Last.
that's the only problem with that is now we have had created a little perf here in the
We'll
past.
see a little bit. Last. And also, you want a new conference at 12 try or no? We're done.
No, have you been monitoring the ACT during the case or
We don't
not
with the
really?
angiomax.
Yeah.
No, but now since we stopped at one
Such a
point, I
long-
think it's the time to
Okay.
monitor it. Yeah.
We can't give the ACT.
I'll not, don't give any dye. We know where.
This is just a drilling wire, so I don't think it is going to help us to re-enter.
Okay, little counter lateral.
I think it's in the same place.
Yeah, same place, exactly.
See?
I've-
Then
Right there. Okay.
okay, little dye.
That funny loop means you are not in the lumen. Okay, could be.
Well, very different there.
No.
No. No.
Or subintimal. You want to advance the fine cross a little bit? Could be the
No.
no. Now you are in the
No.
lumen.
1 second. Inject.
No.
The same thing which you went one time,
Yeah.
right?
Although
You know
this,
what?
this
One
time
second,
I
I
think
want-
this time we are more distally.
No, but in the distal you are not in the lumen.
Yeah, little die again, just see. No, but I just 1 second.
No, we're not. Don't even know. What you could do is advance the thing
Fine
and
cross?
we find cross and we try to use it. Can you advance?
Okay.
Then I try the different wire. Subintimal. Okay, good.
Fine cross
Don't
is
go
here.
more than that.
Yep. Okay. Just 1 second. No, 1 second. Okay, now let's see if the wire goes easy.
Pull back more. You're
Okay.
a lot. Pull back
Okay,
more,
little line up,
more
yeah.
at the level of the heart. It's all subintimal, so you cannot. You have to pierce it now. Then you will lose the entire. Take it out.
Okay, which wire you want?
I have. Don't worry. Take it out.
Okay.
You have the confiance at 12 new.
Turn me off for a few minutes.
With the confiance,
Go
are
and
you
do your
going to
slide.
keep the
There
fine
will be
cross
long time.
exactly where it is or come back?
You go and do your slide.
Yeah, I think we have created
Why, what is
subintimal
going
channel,
on?
so let's try.
There are more cases. Two stents or one?
It's behaving very differently there.
Yeah, good. Done. We'll bring back again 3 months.
No.
Under Lynn Glasser, yeah.
Same, no. Somewhere, going somewhere else. Yeah, no. Oh.
It is so very deceptive, you know, each time you have a feeling that, and this is going back exactly the same place. That is a different channel. No? No. Anu, as you are approaching this particular part of the case, your biggest concern is the dye load, no?
Yeah. Right now, dialogue and radiation
Yeah.
to the patient and the operators. Okay, this is what we are thinking now. I think it's time to make a decision.
Yeah. Yeah.
Give me the.
So I've been,
This was a starter we were trying, but has
Yeah.
done nothing.
look, I've been holding back a question for the last 45 minutes, and I'm going to hold it for a few more minutes.
Are you bringing the patient back?
Yes, exactly. I didn't want to jinx ourselves, I didn't want to discourage myself or you, but the thought which has been coming is, if this patient is brought back, would you first try antegrade?
Yeah.
Because we've created so many micro channels and the wire may
Yeah,
just
wire
drop
may
into.
just find a way.
That's what I was thinking. I mean, if there has been same place. Yeah, see there it goes somewhere there in the right channel and then switches into a subintimal. This is the subintimal path there. They're different, very different there. And good to know that our audience has not abandoned us.
Okay, now.
Same place. Anu, as I've been observing this, I almost get a feeling as if the fine cross is directing the wire
No?
and that the right. Yeah, that's one of the thoughts I
pulled
had.
back.
Yeah, that's one of my only thoughts I had, just having watched you struggle with this, that are we too far with the, but it tracks exactly the same path.
No? No? No.
Same place.
Yeah, still give the bar. No good, right? Hey. You give some dye? No.
You would not consider exactly where the fine cross is at that level, putting in a small balloon?
There?
Yeah, I'm just wondering if
Somewhere here we get out.
right, get off track there.
Same thing, huh? Should we just do at least the whisper, knowing that we have
Some
gone
dye?
through? Yeah.
No, not same. I think it's the same. Whisper. Okay, get the whisper before you hit.
The whisper basically deflecting off the subintimal channels.
So, Samin, at this stage, are we out of ideas or out of wires?
No, I think out of ideas or just same. This
I mean,
is
just about
same
every-
5-10% of cases where
Yeah,
they'll be unsuccessful, and you bring back patient about 6-8 weeks later and retry.
And this is what I was, when you were not there, I asked Anu the same question. You would retry antegrade,
yeah,
no?
definitely, yes. Yeah, we'll try, we'll bring him back and
Because this could be a straightforward case after that.
that
One
time.
of these micro channels could have
yeah,
reconstituted.
exactly. And This is actually, if you recall, I mean, you remember that patient which we did?
Yeah, exactly the same case.
Perforation came back, better channel, we are done in 30 seconds in the symposium.
Yeah.
We failed in the CCC live webcast, and then we brought back, because that was in April, and then in June we did a live in the symposium.
Straightforward.
Yeah, straightforward. Because I think taken everything together with the dye, and so we are given
just about every.
You want to try the whisper?
Yeah, I definitely, before giving up, little dye again, try the whisper.
Look, but right from the beginning, this case had the making of exactly what we have seen, you know, that it would be extremely difficult for all the reasons we thought.
Yeah, absolutely.
So no surprises, at least. And
good.
In
Let's
fact,
get the whisper now. 1 second.
the surprise would have been, have we, okay, there it looks, no, same place.
Good. So I
You
think
want
that's
to
it.
try the whisper from the beginning?
No, just from here, at this level, because whisper will not puncture any of the subintimal channel. I mean, once you are there, it may just get into the main. Put a torque, guys, on this wire. I mean, it's so rare to have non-success of even retrograde.
Retrograde.
The only question of retrograde will be that if you have some different channel distally. Sorry. Don't give any dye because we know where it is. Quit.
Maybe the same.
Same place.
Give some dye for the RCA. Maybe I took it out.
No, okay, let's engage the guide. That guide also has lengthened.
Okay, no.
This is the same place.
Yeah. Go.
There's a little dye.
Oh. Yeah, you're outside.
No, but it's okay. Just with the parallel.
Pull back. Get your fine cross further and maybe no, that's not there. Up. Like in 2 o'clock position, you have to change. Try the builder. Come up like this.
Okay, 1 second. Let's study the old picture.
See
Last
here,
one.
we have so many channels, right? Right here, I think if we can pull back 2 o'clock position, yeah, right there. Yeah. Die could be, no?
Dye a little bit again. No.
I think for your left is cross boss.
Yeah. Okay. If everything is okay.
I mean, would it make sense as a last attempt to come back significantly with the fine cross and try it a little higher with the whisper wire? Maybe with a little shape different or something, because we may be going subintimal right very proximally.
right now? This maybe slightly different.
No.
At least the septal has opened up better. I think 1 o'clock position if it gets in, no? Let's try Fielder also.
The Fielder XT or which one?
Fielder. Oh, Fielder XT you want to try?
If you want to try the last wire Fielder XT, then fine, right?
Okay, get us Fielder XT. Not yet.
What is the ideal timing of getting a patient back?
2 months.
2 months.
Pablo, check room 1 if they're done.
The one case was done of Contreras.
Done? Nothing?
Yeah.
See, the only other technique that has been described, right? You want to mention that or leave it?
Yeah, will be cross boss,
Yeah.
subintimal wire positioning.
Are we in the right view?
Is LED or RCA is very damped.
Hold on. Which is RCA color?
Now always have to be careful when you see the dampening. Yeah. That there may be some clot formations and so
Right.
in the guide catheter. So very important that don't inject forward because we saw tremendous dampening
In the
in
guide.
the LED guide, and you see that hole full of clot. Show that. That's very important. So this is the key, and this is where then you inject, everything goes in. So don't go
Right.
forward. Can we zoom it? That
Yeah.
clot. This is despite the therapeutic anticoagulation. I think we stop it here. This is another signal, which
Right,
I believe
right.
in God's signal that it's everything is okay, guys. No harm done, unsuccessful only, and bring back the patient later.
Let's do a check an ACT. You want
Yeah.
to try?
Yep, that's fine.
Check an ACT.
Yeah, so but the catheter, long time, and this is in the guide catheters or so, they all will be associated with extra
Thrombosis.
clot formation and thrombosis and so, yeah. Good, that's fine. That's
No,
good.
we want to take one picture so we know all the vessels are okay. Okay.
Good.
You there?
You can just, yeah. Good. Take one low mag, yeah, good. So we are still there, all good. Okay, I think this we have been a long marathon, but it's about time sometimes to just say no complication occurred, but let's stop it. So if we can take to, yes,
What's
it's
the
a,
dye use, Pablo?
it's a depressing, the time, our fluoro time is how much? 72 minutes. No, 98. So the 100, we always have said 100 minute is the
Right. So
maximum, so we write there. So we can just come quickly, we say the two take home message, which is the higher MACE and vascular complication in high radial centers and the predictors of first time CTO success. The recent data have suggested higher MACE and vascular complications at centers with high radial procedures volume. This may just be due to lack of expertise in femoral access due to too much emphasis on radial techniques. Hence, continuing femoral access technique education is of prime importance in emerging breed of radial interventionalists. Very important. Don't ignore your basic. Second, the clinical and lesion related factors can easily identify CTO lesions likely to be associated with successful procedure. Hence, these factors can easily be used in selecting the CTO lesion likely to be associated with positive outcome. Like this case, we gave a 70% success rather than our 90% because patient has a blunt stump calcification and the long lesion. The initial short-term randomized data have shown no effect in LV functional parameters with CTO recanalization. Quickly, 3 questions. Following statements are true for the radial paradox, except that higher femoral complications in high versus low radial centers, higher MACE rates in high versus low radial centers, higher vascular complications in low versus high radial centers, higher femoral vascular complications with both diagnostic and therapeutic procedures in high versus low radial centers, and higher femoral complications at high radial centers in patients at low risk of vascular complication. So, this is the paper we described. Second, meta-analysis of randomized clinical trials in ACS have shown that the radial procedures are associated with following lower adverse cardiac events compared to femoral procedures: mortality, non-cabbage bleeding, myocardial infarction, stent thrombosis, A and B or A, B and C. Then lastly, following are the independent predictors of successful CTO recanalization except severe calcified lesions, prior cabbage, blunt stump, non-CTO, location and duration of CTO. So, with that note, I think we stop here, and it has been those who have been with us over 2 hours, we really thank them, but hopefully, I mean, again, the plan would be in this particular case, bring back in about 2 months and give it a try, and it could be that we will have a better channel and will be much easier procedure at that time.
Samin, I think you've said it most accurately. Humbling case, but I do believe that it has provided a great educational value. We'll hopefully be able to provide you feedback on this patient at some stage, and see you next time on February the 16th.
Okay. All right. Thank you.